Hello, everybody. I hope y'all had a wonderful long weekend. I hope you were enjoying this Monday that we have off of school technically. I know we're all still working, but that's just the nature of the beast. But let's go ahead and get right on into it. So we're starting out with the gross anatomy of the heart. Gross anatomy meaning the actual structures of the heart. And I think a good place that I want to start is talking once again about that tracing of the blood cell through the entire cardiovascular system. So we're going to start with the vena cava, which is that large vessel that empties into your right atrium. Then your right atrium contracts and it goes into through the tricuspid valve into the right ventricle. And then from the right ventricle, it goes into the pulmonary artery, which is the only artery in the body that carries unoxygenated blood away from the heart into the lungs where that gas exchange happens. It drops off the CO2 it's carrying and grabs onto an oxygen molecule. It then goes into the pulmonary veins, which are the only structures that carry, the only veins that carry oxygenated blood to the heart, into the left atrium. When the left atrium contracts, it goes through the mitral valve into the left ventricle. And then from the left ventricle, it goes out the aorta to the rest of the body. Okay. And then from there, the aorta, what did I say there? Sorry, goes from the left ventricle to the aorta. And then the aorta splits off into multiple different arteries. Um, and those arteries split off into arterioles. Those arterioles go down all the way to capillaries, which are, like we said, one cell thick. They're just big enough for one blood cell to kind of squeeze through. That's where that gas exchange happens, where that oxygen is dropped off and CO2 is picked up from the body. Then it goes into a venule, which turns into a vein, which turns into the vena cava, which then goes back into the heart. And that is the main journey of these blood cells. They do that over and over and over and over and over again for your entire life, right? Some other important parts of the heart are this septum right here, that is this thick piece of muscle that separates your left and your right ventricle. Something I want to clarify once again from last week that I kind of confused y'all a little bit. There are four chambers of the heart, your two atriums and your two ventricles, and they are completely separate structures from one another. Any kind of mingling between the two or between any of them, any leaking between any of them causes massive issues in the pressure that your heart is putting out and your cardiac output, which is how much blood your heart is pumping out. Let's see. Let's go over here to ooh, he's not wanting to. There we go. I really like this diagram because I feel like it makes the muscle cells in the heart look like little monsters because they have little eyes. But anyway, it's fun to me. So the wall of the heart, arguably one of your most important structures in your entire body, is separated into some major parts. The endocardium, which is a smooth endothelial layer that allows blood to just kind of flow freely in the heart as it needs to. Then the myocardium, myo meaning muscle, cardium meaning heart. So your heart muscle, your your epicardium, which is that outside layer of epithelial tissue that protects that myocardium. Attached to that epicardium is the visceral pericardium. And then there's a fluid-filled cavity between the visceral pericardium and the peritoneal pericardium. Now, let's talk about the pericardium itself. It is a sac around your heart that is, again, fluid-filled, and it has several functions. It keeps your heart lubricated so that you don't have friction against the other structures around your heart when it's beating. It protects the heart from infection by keeping anything out that may get into your body from attacking that heart muscle. And it also helps the heart it helps regulate how much the heart is expanding. It keeps it from expanding too much. So it helps protect that so your heart doesn't become injured by stretching too much. Let's see, the electrical conduction system of the heart. We talked a little bit about that the other day. And ooh, I don't know if y'all can hear my cat. He's trying to get in. So in the electrical system of the heart, it's actually relatively simple comparatively to some other structures. So you have your SA node right here, your sinoatrial node, which is your primary pacemaker of your heart. It tells your heart how fast to beat, when to beat, yada, yada. It sends out a signal that travels all throughout the atriums so that they contract first. It then goes to, I just pointed. It then goes to the AV node, the atrioventricular node, because it's in between the two, where that signal is paused for a moment so that the atriums can finish contracting before the electrical system goes into, or the electrical signal goes into the bundle of His and then into your bundle branches right here in that septum or sinus like we talked about. And then into the Purkinje fibers where it terminates right here. So where that nerve ends, that's where the electricity kind of grounds, terminates, and it's no longer doing anything. And the reason for this is because that lub-dub motion that we think of when we think of heart, or lub-dub sound we think of when we think of a heartbeat, the first beat, the first lub, the first bump sound is your atriums contracting. And the second louder sound, bump, is your ventricles contracting. And the reason that this is so important, that this electrical system is so important to be this way, is because if your whole heart fills with blood all at the same time, all of your valves are open, everything is open as that heart is relaxing from that last beat. So everything is full. And then those atriums contract, which pushes all the blood that was in the atriums into your ventricles that are already full in a relaxed state, and it stretches that muscle out, right? It pushes that muscle out, and so it has that tension to it. And then the muscle itself beats, and that beat is what allows the valves in your aorta and in your pulmonary artery to open up and push that blood out. So that's the stretching that occurs and that bounce back from that stretching plus the actual contractile force of your heart muscle is what allows for those things to happen. Sorry, I'm not used to recording myself, so yeah. Let's see. We're gonna pause for a second. Okay, so the valves of your heart. You have your tricuspid valve here, and it's called that because it has three cusps. And your bicuspid valve, which are in your left and right, which are between your ventricles and your atriums. And then your semilunar valves, which are the same thing but for your aorta and your pulmonary artery. So your pulmonary artery is here, and it's also called the pulmonary valve, and your aorta is right here. And that, like we said, is to prevent backflow. You don't want, once your blood gets somewhere, you don't want it to come back the wrong way, because that puts unnecessary pressure on the heart muscle. Let's see. So going back to that electrical system in the heart, right? Let's see if we can't make this a little bit bigger. Let's move all of you out of the way. So in a normal heart that is beating normally, and you can see it here too, this is what we call a normal sinus rhythm. Okay, yeah, a normal sinus rhythm, okay? You have that P wave right there that we talked about that denotes the SA node firing. So that is when the SA node is sending out that signal, and as soon as it does so, the ventricles contract. And then this pause right here, this little line, is it being that signal being stopped and paused by the AV node. And then your QRS complex, which is the little spiky guy, is your that signal going all the way through the bundle of His, your bundle branches, and the Purkinje fibers. And then this little bump right here, we call that repolarization, which we're not going to get too deep into because that's that resting membrane potential stuff that we all got really frustrated with back in the neurology chapter. But essentially, that's just the heart. Think about that as the heart relaxing and going back to a state where it's ready to beat again. Something kind of interesting that you can see is that if you have a bundle branch block, which is these bundle branches right here that kind of break off, that means that there is a break in the electrical system. It's not a heart block that you would think of like a heart attack where an actual blood vessel is clogged. It is just a block in the electrical conduction system of your heart. So there's a wiring error. It's kind of like whenever you have an old house and there's that one light that just flickers when you turn on the stove or something. You know, it's that kind of thing. But this is what we call a bundle branch block, and this is a right bundle branch block. So, because I did a right one because it's easier to see. That means that this cord right here, the one that's branching off to the right from the bundle of His, there's a little bit of a delay that this one is not conducting quite as fast as the left. And so what you'll see in an EKG as opposed to a normal one is where you have this QRX complex, it'll be branched off because you have two different electrical signals being detected at the same time. And that causes this spiky look to it. So you can think about that as kind of a separation, but like everything is going right. So you have the P wave and it's going into the ventricles fine. The SA node or the AV node is working fine. But once it gets to those bundle branches, that signal is a little bit slower. And so you have two different times whenever that heart muscle contracts. So you have two different peaks there. Just a way to visualize it. Let's see. Let's talk about the concept of fibrillation again. So what is fibrillation? Fibrillation is whenever your heart muscle is not contracting at all. It's just kind of twitching. It's just kind of fibrillating is what we call it. And that's a problem. And we talked about that a little bit with AFib, atrial fibrillation, because if blood doesn't move properly, it clots. And these patients can have blood clots that exist within their atriums. In addition, they don't have that atrial kick that we talked about, that squeeze or that beating of the atriums to push that blood into the heart to stretch it so that that bounce back helps with cardiac output. They don't have that either. So their general cardiac output is lower. It's you also see that there is no real rhyme or reason to how their heart rate is, how their heart rhythm is, we call that irregularly irregular heartbeat. So normal sinus is regularly regular. Atrial fibrillation is regularly irregular, meaning that it's irregular, it's not right, but it does so consistently. And then AFib is irregularly irregular, which means that there is no rhyme or reason to when the ventricles are contracting at all. They're just doing their own thing. And part of that is because the SA node isn't firing, the AV node kind of takes over and helps to continue the heart beating. That way, if this guy decides he's going to take a vacation, this guy can kind of handle it a little bit. And it gets deeper. Every part of your electrical system can fire a signal on its own, and the lower you get, the worse it is. But those are the big ones to remember there. So ventricular rhythms that are a massive problem that you may see. This is when your ventricles are the ones sending the signal, period. Okay. And here we have two very different ones, VTach and VFib. So ventricular tachycardia is whenever that electrical signal is just coming from the ventricles. That's why it's so wide. And it's just the ventricles are going boom, 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 boom. Atriums really aren't doing anything. Basically your ventricles are doing the funky chicken. And this can be, we call it pulseless or with a pulse, but irrelevant. Sorry, strike that, scratch it. Whereas VFib is like we talked about earlier with AFib, those ventricles are just kind of twitching. There's not really anything going on. There's no rhyme or reason to the electricity or how it's moving or really if it's moving. These patients are always dead. This is what we call a shockable rhythm. If you watch Grey's Anatomy and you see people doing CPR and they go clear and you see that line, that asystole on the monitor, that's not what happens. These two rhythms right here are the two most common rhythms that do get shocked, because what happens when you're shocking or defibrillating a patient is that you're sending electricity through that heart muscle and you're trying to basically restart the SA node. You're trying to get that SA node to send that signal again. You're trying to get that process of electricity flowing back through the heart again and get it making its own electricity again by providing that shock. Okay, let's see. The major blood vessels of the heart. I think this gives a pretty good description of them, this slide I found right here. So you have your coronary arteries, what's interesting about the heart is that it is not really, it's not fed by the pressure that it puts out, like the rest of the body. So the rest of your perfusion, which, as we talked about, is the ability to get stuff places. So if you're hypoperfused or you're not perfusing, then you'll see signs like cold fingers and blue fingers, because those structures that are far away from the heart, by the time it gets there, there's not enough stuff, or there's not enough stuff being pushed that way to feed those structures. But it is perfused by a backflow, which means that whenever the heart contracts, it pushes that blood out, and then when it relaxes, that there's not a valve to keep it from going into the heart muscle, so it just kind of flows down into the heart. And the main structures that do that are the main structures or arteries in the heart are the left coronary artery, the left circumflex artery, the left anterior descending artery, or the LAD. We talked about this one as a very important artery. The right coronary artery I don't think that one's relevant. So we're just gonna go to the right coronary artery. So remember those: left coronary artery, left circumflex artery, left anterior descending artery, and right coronary artery. So the left coronary artery feeds the main portions of the heart. It feeds the left side of the heart, the entire left side of the heart. Breaks off into the left circumflex, and what circumflex means is it goes around the back. So the left circumflex feeds the structures to the back of the heart, and it branches off to feed that muscle, whereas the left anterior descending artery, anterior meaning front, it feeds the entire front left side of the heart. And that front left side is so important. My paramedic teacher, whenever we got to cardiology, made the joke, and it really isn't a joke, it's true, that cardiology from the context of paramedicine is really just a left ventricle class, because the left ventricle is so important to pushing because it pushes that blood out to the rest of the body, allowing everything to function. So, and then the right coronary artery does the exact same thing as the left coronary artery, but to the but to the right side. Yeah, okay, let's see. Some common heart-related problems or pathologies that affect. Actually, I'm sorry, I'm skipping a step. I kept telling myself to move this slide so I wouldn't forget it, and then never did. Okay, so your vasculature, okay? Remember, we have that artery that has that thicker layer of muscle because it contracts and expands depending on your body's perfusion needs to increase or decrease blood pressure, respectively. And you have your veins, which are more relaxed. They don't really contract or expand very often, but they do have those valves in them which prevent backflow. The valves in the veins do the exact same thing as the valves in the heart. They keep that blood from backing up to where it's already been. Some terms to remember are the tunica intima, which is that inner layer of tissue, that inner endothelial layer of tissue inside of the vein or the artery. Remember, intima means inside because it's very intimate. If you are like if something is intimate with you, it's very close to you, it's inside of that vas or of that vessel. The tunica media, which is the median between the two major layer or between the two inner and outer layers, and the tunica externa meaning external or on the outside, which is that protective thick layer on the outside of the vessel. And then a capillary here, you'll see it's a lot thinner. It's basically just a few cells thick. And it's that way because it's that permeable part of your vasculature. Okay. When I say permeable, I mean things can pass in and pass out. Sorry, I'm sitting on my legs again. Oh, my knees. Okay. And it has to be that way because this is where the exchange of nutrients and specifically oxygen is happening, where that red blood cell from the artery dumps off that oxygen molecule and grabs onto a CO2 molecule to carry it to be expelled from the lungs. And here you can see that capillary, or here you can kind of see that vena cava breaking down into veins, breaking down into venules, which eventually turn into capillaries, like we talked about. Okay. Couple common disorders that affect the cardiovascular system. This is called left ventricular hypertrophy. Hypertrophy meaning too big. This is whenever the muscle of the left ventricle is entirely too big. This can cause different kinds of heart failure. Heart failure being a general term for any condition that causes your heart not to or any condition that affects your heart's ability to effectively pump blood is heart failure. So that is ventricular hypertrophy. Cardiomegaly, on the other hand, as opposed to hypertrophy, is just a heart that is too big. So in cardiomegaly, the entire heart is blown up. It's Grinch syndrome, where your heart grows 3 sizes, whereas hypertrophy is just going to be a part of the heart muscle has gotten too big. Let's talk about MI, or myocardial infarction, more commonly known as heart attack. So whenever an artery is plugged, stuff cannot get places. In this context, oxygen. Oxygen cannot get to the heart. Your heart is being starved of that, excuse me. Your heart is being starved of that fuel, that food that it needs to continue to pump. And so any musculature beyond the point of that clot is not going to be able to function. It's going to immediately start dying. That's what we call ischemia. Whenever your tissue starts to die, that is ischemia. The symptoms of this are going to be pretty much, a lot of people know them. It's that referred pain to your left side, specifically your left arm and jaw. These patients can become pale, cool, and diaphoretic. Diaphoretic basically meaning medically sweaty. Those symptoms of shock start to present. And yeah, let's see. Oh, I want to go back a little bit to the vasculature real quick. So one of the talking about the mechanisms by which the systematic vascular resistance is activated. So if I am running, right? If I'm running and I'm getting hot and I need more muscle or more blood to start pumping towards my legs and my arms and whatever muscles I'm using, my body is going to tell my heart, hey, we need to pump faster. And it's going to say, okay, cool, we can do that. We can pump faster. So your heart's going to start pumping faster. And in response to that, your pressure is going to go up, but also you're going to be sending the signal or your muscles are going to be sending the signal saying, hey, we need more blood. And so your vasculature is going to say, okay, and it's going to expand. That's why your face turns red. That's why that's why your face gets red and hot whenever you're running or you're doing any kind of strenuous activity, because all of those vessels are expanding to allow more blood to flow. Conversely, if your vasculature just kind of expands, for one reason or another, whether it be whether it be a condition or a drug or a medication or whatever, if it expands and all of a sudden that pressure from that the heart is receiving back drops, your heart might react um, by contracting faster or harder or whatever the case may be. So the interaction between the heart and the vasculature is paramount to your body's individual needs at the time. So at rest, your heart rate's going to sit at, let's say, 80 normal, between 80 and 90 normally. And your blood pressure with your vasculature just kind of operating as like mine is right now, or yours sitting there is right now, is about the base is about 120/80, but those numbers can shift and change depending on the different parts of your body communicating with your nervous system and your endocrine system to tell your heart and your vasculature what they need at the time. Hey, it's getting really, really, really cold. We need to shunt blood to our core to keep warm. And so you're going to get pale. Your fingers are going to get pale and blue because all of those structures are contracting to keep your important bits warm. Hey, we're hot. We need to put off heat. Okay, we're going to expand and let more of that hot blood out so that you can radiate that heat out of the blood in addition to sweating. Yeah, and that is the vasculature, I think. Yes, okay. Let me look at my notes. MI, hypertrophy, congestive heart failure. So, congestive heart failure is a specific kind of heart failure where one or both of the ventricles is not contracting correctly. And it causes a litany of symptoms, including one of the main ones, which is pulmonary edema or pedal edema. So whenever your heart is not functioning properly, whenever one or the other side is not pushing out correctly, you have a buildup of pressure, of back pressure from one side or the other. So let me double check myself here. Actually, I'm going to pause real quick. Give me just one. Okay, I'm back. So if your right side of your heart is failing, right, and that blood isn't being pushed out, but it's still being pushed on by the left side of the heart, that will cause what we refer to as pedal edema. So the pressure within your vasculature, your lower vasculature, is so high that that fluid starts to leak out of those capillaries instead of just doing gas exchange and fluid exchange as the body would normally need to do to maintain homeostasis. uh, the fluid within your blood leaks into the tissue, and that can cause pedal edema, which is just swelling and fluid within that space. Whereas left-sided heart failure, which is largely considered to be the worst of the two, means that your left ventricle, which is pushing blood out to your body, is not pushing out effectively. So you have that back pressure in your lungs. Because remember, your right side of your heart pushes that blood to your lungs, and it's still doing that, but not all the blood is able to get into that left atrium and then left ventricle. And so you have that backup of pressure within the lungs, and that can cause pulmonary edema, which is that fluid is third spacing, as we call it, into your lungs. And lungs that are full of fluid cannot expand properly. Or can't exchange gas, can't expand properly, and these patients end up being very, very, very short of breath. In addition to that, just the long-term effects of heart failure can be just the same effects of hypoperfusion, where your body isn't healing properly, your other organs will start to feel the effects of not being perfused correctly, and over time, that will start to affect and cause problems with your other organs. Let's see, what else did we want to do here? Okay, atherosclerosis. We talked about that a little bit. I do not have a diagram, but atherosclerosis, still can't say it right, is the hardening or buildup of material in your arteries. Okay, it's primarily what will cause heart attacks because that buildup will start to get more and more, and then your vasculature will contract. But also, in general, it will cause your arteries to not be able to expand and contract properly as they need to. It'll cause blockages within your body. Those blockages can break off and cause all sorts of problems. Triple A's. Let me actually real quick. I'm gonna put y'all over here for a second. I knew there was a diagram that I forgot. And we're back. All right, so a triple A is hold on. Abdominal aortic aneurysm. Okay, that was abdominal, just wouldn't pop into my head. Whoops. So in a normal aorta, so this is the main branch of your body, like this is the main artery for your entire body. It runs all the way down from your heart through your chest and into your abdomen. So this is kind of the abdomen part of it. And a good way to think of it is these are the two arteries that go to either one of your legs. So it kind of looks like a little torso, right? And this is an aorta with a large aortic aneurysm. So let's talk about what an aneurysm is. So whenever your tunica intima of your arteries specifically, can't happen to veins, but more likely arteries, is torn, it tears off a little bit and it does not heal properly. It can start to form a pocket of fluid within it. And that pocket, because of that pressure that is being pushed, and the aorta, especially the descending aorta, has a massive amount of pressure on it from both the heart and gravity. It can get bigger and bigger and bigger and bigger. This is a deathly fear of all paramedics. I have never seen one in person, but um, I have had a couple scares. When I say seen one, I mean the major thing is if you like push on their belly, you can feel it like doom, 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 doom. And it's not like just feeling your heartbeat through your diaphragm. It's like your hands being hit by a hammer, apparently. Like it's very, very bad. These patients, when this bursts, they have a very, very high mortality. Basically, what you have to do is I watched a surgery on it one time. They go in and they completely reroute the upper part of the aorta so that they can open that part up, and they just scoop out handfuls of congealed blood and material out of that space, and they repair it. But unless you like fall, basically, if one of these bursts, unless you fall on a table with a surgeon that is already ready to perform the surgery, you have almost 100% likelihood of mortality. So these are very, 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 very bad situations. Let me see. I'm going to see if I want to touch on anything else. I think I hit everything with the cardiovascular system. We talked about the action. So let's just do a quick recap. We talked about the gross anatomy of the heart by talking about how a single drop of blood makes its way through the entire cardiovascular system. We talked about the components of the cardiovascular system, meaning the heart, which is the pump, the vasculature, which is the tank, and the fluid, which is the blood, okay? Or the blood, which is the fluid. We described the actions of the cardiac cycle, and yes, we described the structure and functions of the body's vasculature. And we talked about some common diagnoses that you'll see with the heart. Excellent, excellent. Let's move on to the lungs. All right, so your respiratory system. So we have a saying in EMS. It kind of goes along with what we call the KISS method. The KISS method is keep it simple, stupid. But blood goes round and round, air goes in and out, anything else is a problem. That's why it's my nature to say that these two systems are so important. This is, we just talked about the blood goes round and round part. This is the air goes in and out part. So the main structures within your lungs. Let's make these bigger. So you have your upper airway. You have your upper airway, which is composed of the composed of the nasopharynx, the oropharynx or oral cavity, the pharynx, which is where those two structures kind of meet, the larynx, which is where your vocal cords are, the epiglottis, which is a small flap of skin that sits on top of your trachea that closes off when you swallow. So my epiglottis is open when I'm talking and breathing, but as soon as I swallow, the epiglottis closes so that food and other material cannot get into my trachea and instead goes down my esophagus. Then your lower airway starts with your trachea, which is, you can feel your trachea right here. It's that hard tube that has all those discs on it, those discs made of cartilage. Um, and that goes into your, let's go over here. That goes into your main bronchus. Hold on. Hold on. Let's pause it. Yeah, let me tell you what I did there. In my head, this is like the main stem bronchus. No, that's just the trachea. So the trachea goes all the way down and then bifurcates, which bifurcation just means a split like that. So if you look at your hands, if you can see the veins on your hands and you see one that kind of combines on your hand, that's what we call a bifurcation. So it bifurcates here into your right and left main stem bronchuses, your left main stem bronchus and your right main stem bronchus. And then that goes down into your bronchioles. Yes. Or am I doing that again? Into your bronchi, your smaller bronchi, and those smaller bronchi end up in these really cool little, I think they look like grape clusters, but these little grape clusters called alveoli. And the alveoli is that functional unit of your lungs. Okay. When I say functional unit, you'll hear that again, especially in the renal system. Um, that is where gas exchange happens. Okay. And this right here is chronic bronchitis. We'll talk about that in a minute. Train of thought just crashed. Give me a moment. And we're back. Okay. So that's all the major parts of the internal lung structure. So the lungs are split into several different lobes. So the left lung has 2 lobes and the right lung has 3 lobes. This is because your heart sits on the left side. And if you see, there's a little cavity right here where your heart just kind of fits perfectly. So your left lung is not necessarily slightly smaller, it's just structured differently than your right lung. And then it doesn't show it here, but right at the bottom here, separating your thoracic cavity from your abdominal cavity is your diaphragm, which is that flat muscle that concaves in to pull air into the lungs by creating negative pressure in the lungs. When the pressure is lower, that air wants to rush in. And so even though whenever I breathe, I feel like it's almost a process that like comes from my mouth. Like I feel like that's the active part when I breathe is I feel like I'm pulling in air from my mouth, but you're actually pulling air in all the way down from your diaphragm. And your rib cage is loosely attached with cartilage on to your spine and to your sternum here. And so it's able to expand and contract with it. And that helps to keep our lungs from expanding too much. Um, yeah, okay, so back to the capillaries, right? Oh, not capillaries, I'm sorry, the alveoli. So this shows a little bit better of a breakdown of the alveoli themselves. This is a single alveolus. This is a bunch of alveoli. And you see they all have this little air hole that goes into them. And these stretch and contract just like your lungs do. Um, they're kept lubricated by a substance they secrete called sebum. Um, and they are covered in capillary beds. And so capillary beds being those very, very small uh, vessels where basically one red blood cell can fit through to dump off um, CO2 and take in oxygen. And this very thin membrane of your alveoli is where that happens. So as you can see here, red blood cell drops off CO2 and CO2 gathers in your lungs and is expelled, whereas oxygen gets picked up by that now empty hemoglobin molecule within the red blood cell and carries it out to the rest of the body. Okay, let's talk about drive. So respiratory drive, what makes us want to breathe? So breathing can both be active or passive. You're not always thinking about breathing. If we always had to think about breathing, we'd never get anything done. We'd only ever be worrying about breathing. So your body, when you sleep, whenever you're not focused on it, will automatically trigger that diaphragm to contract so that you'll pull air in. And there's different ways that it does this. The two main ones are O2 drive and CO2 drive. So the chemoreceptors in your blood, remember we talked about how there are stretch receptors, there are pain receptors, there are uh, heat receptors, and one of the most common kinds of receptors in your body are chemoreceptors. And there are specialized chemoreceptors within your vasculature that detect how much CO2 and how much oxygen is in your vasculature. And so in a person with a healthy person with healthy lungs and healthy vasculature, we are on what is called CO2 drive. So basically, when our CO2 gets a little bit too high or we are hypercapnic, it will trigger our body to breathe. So in a healthy body, it's not your need for oxygen that's triggering that. It is your need to expel the waste of CO2. Somebody that is chronically hypercapnic, like somebody with emphysema or other kinds of COPD, that their lungs aren't functioning properly, so their CO2 is always high, they go to O2 drive, which means when their O2 is low, it triggers that breathing. And this is bad because it makes it to where your body is not keeping a consistent amount of oxygen and or is not keeping a consistent flow of oxygen, but rather trying to compensate for a lack of oxygen, which, going back to perfusion, means that you do not consistently have enough stuff to keep everything going. Nothing has enough fuel. And over time, your entire body is going to start to feel the effects of that. Whereas with CO2 drive, it's really just, being a little hypercapnic isn't a huge deal. Being a little hypocapnic isn't a huge deal. Whenever you have an anxiety attack and you're hyperventilating, you're breathing off a lot of CO2, you'll get dizzy because you are hypocapnic, and your body will eventually pass out to reset everything, and you'll wake up and no longer be hyperventilating. Let's see. Yeah, so let's review hemoglobin real quick. I just want to hit that one more time because this is one of those links between the cardiovascular system and the respiratory system that we talked about. So well, let's make this. No, how do I make this bigger? Oh, bigness. Cool. There we go. And we're gonna make it red. So well, that's not even good. Anyway, so you have that protein that is just all loopy and wrapping around on itself and going everywhere. And it has those, oh, opacity. Oh, there we go. There, now we're cooking with gas. Okay, cool. And it has those four iron molecule or four iron atoms that sit. I guess they're all going to be different shapes. Those four iron atoms that sit there that kind of act to hold it together and act as hinges. And the structure of that allows it to grab on and bind to that oxygen and release it, and then grab onto a CO2 and release it. The reason it can do that is because it is designed to grab both. That's one reason why CO2 poisoning is so bad. So when it pulse oximetry, you know, when they put that finger on your or that little thing on your finger and it tells you what percentage of oxygen you have in your body. What's interesting about CO2 poisoning is that your hemoglobin will become bound to CO2 when it should be bound to oxygen because of the high concentration of CO2 in your blood. And that pulse oximeter just reads the percentage of saturated hemoglobin. So the amount of hemoglobin that is attached to something within your vasculature. And if everything's running correctly, then it's usually oxygen, but in the presence of high CO2, it'll be CO2. So you could be poisoning your entire body with CO2 and you still read that you have plenty of oxygen, even though you don't. There we go. Let's see. Let's see here. Where are we? Common pathologies that affect the respiratory system. You have several in your book that I definitely want you to, oh, nope, 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 nope. Okay. There we go. That I definitely want you to look over. But some of the main ones that I want to talk about are COPD. Lots of people in the South have COPD. Lots. And COPD is chronic restrictive pulmonary disorder. And that means that your chronic restrictive means that there is something keeping your lungs from either receiving air or blah, 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 blah. There we go. But it means that either you are not getting air in, like there's an actual physical obstruction to air entering your lungs, or there's an obstruction to that gas exchange in the alveoli that we talked about. So emphysema is characterized by the hardening or decrease in effectiveness or stretchiness of the alveoli themselves. So if you see here, you have these nice little bubbly grape clusters that are doing what they're supposed to do and expanding and great. And these ones are kind of all hard and not expanding properly. And that affects their ability to exchange gas. Whereas chronic bronchitis, remember, itis means swelling or inflammation and is commonly associated with infection, but is not necessarily always caused by infection. Chronic bronchitis patients have a chronic inflammation of the bronchioles, right? Of all of those little structures that lead to your alveoli. And they also can be full of mucus and secretions and several other things. The emphysema patient, whenever they're having a flare-up or they're having an issue with breathing, the main thing you're going to want to give them is oxygen, whereas this patient that has a smaller tube and a lot of mucus, you're going to want to give them what's called CPAP, because that positive pressure is going to push that fluid out of the way and is going to help to push those airways open. You always have a little bit of air in your airways because for this reason, because you want a resting pressure within your lungs so they don't completely collapse upon themselves. Because if they completely collapse upon themselves, they cannot expand properly after the fact, or at least not consistently. Yeah, so you can see kind of at the alveolar, or that's not the alveolar level, sorry. You can see kind of right here where that mucus is building up, causing that physical obstruction. And then in emphysema, your alveoli are sick, and so they are not able to effectively exchange that CO2 and oxygen the way they're supposed to. Pneumonia is one that we talk about a lot, or that we see a lot, and it can be caused by several different things. It can be bacterial, it can be viral, it can be fungal, it can be all sorts of stuff. But pneumonia is an infection of the lungs. And so this is going to cause both that physical obstruction to air getting in where your bronchioles are inflamed and infected and secreting all sorts of mucus and stuff to try to get all that stuff out. And you also have that fluid filling up within the alveoli themselves. So you have that physical obstruction to gas exchange happening. Okay. So those alveoli that are affected, that are filled in with fluid, are not exchanging oxygen very well. This is treated with antibiotics and sometimes with oxygen and other things. Your epiglottis is actually a very important part of preventing this, because we talked about how your epiglottis closes so that food will go down your esophagus instead of your trachea. In patients that have a dysfunction of the epiglottis or are on a liquid diet or just don't have good swallowing muscles, sometimes they will get what we call oh my God, pause. Okay, I found my brain. So aspiration pneumonia is what it's called. So whenever that epiglottis isn't working right and you end up getting something into your lungs that you're not supposed to, it's called aspiration. So whenever you get into the pool and you open your mouth and some air it goes down the wrong pipe or something goes down the wrong pipe and you start coughing, that's because your body is trying to expel air quickly to prevent aspiration, because it's gotten past the epiglottis and that's a problem. So you start coughing to expel it out. When these don't work, whenever a patient doesn't have that coughing reflex, whenever that patient has a defective epiglottis or just doesn't swallow properly or whatever the case may be, and something gets down into the lungs, that can cause what we call aspiration pneumonia. And this is a very, very serious condition. It requires a lot of suctioning. It requires a physician to really pay close attention to your lungs and whichever lung is affected, because that foreign material within the lungs cannot just be treated with antibiotics. You have to get that thing out one way or another. Let's see. Talked about pneumonia. ARDS is acute respiratory distress disorder. It's kind of a general catch-all disorder, which is whenever your alveoli just fill with fluid for one reason or another. That pressure has built up in those capillary beds, and now all of a sudden your lungs fill with fluid. We call that flash pulmonary edema. It can be caused by pulmonary hypertension, which is just chronic high pressure within the vasculature of your lungs. And whenever that pressure gets too high, all of a sudden they dip over that, what we call a respiratory cleft, where that pressure goes overboard and you end up that fluid ends up third spacing very quickly into your lungs, and all of a sudden you're drowning in fluid. Let's see. Actually, on that, I had a patient one time. It was whenever I did that the night watch hitch that I talked to y'all about, where I worked 3 night shifts down in New Orleans. It's a sweet, sweet little old lady who lived on the 2nd floor of an apartment building, because of course she did. And I get in there and she's kind of leaned over her walker and she has a mask on and the firefighters are there. And I'm like, hey guys, what's going on? And she tells me, I feel like I'm fluid overloaded. She was a congestive heart failure patient. She said, I feel like I'm fluid overloaded. And I said, okay, have you felt this way before? Yes. Okay. And that's what was happening then. Yes. Okay. How long has it been going on? A few days. And she tried to increase her medication, which is a medication that pulls fluid out of the body so that you don't have that buildup as bad. And she increased the amount that she was taking there on her doctor's recommendations, and it was just getting worse and worse and worse. And I said, okay, well, we ended up getting her down the stairs on the oxygen. Her oxygen saturation was fine. She was talking to me fine, and we got down there and she was like, it's getting worse, it's getting worse. And I said, okay, would CPAP help? And remember I talked about CPAP? It's a mask you put over your face and it provides positive pressure, so it pushes air into the lungs. And whenever you have a COPD patient or any patient that has fluid in their lungs, that pressure helps to push that fluid out of the way. So that's what I was trying to do there. I was trying to push that fluid out of the way and help her breathe. I said, do you think CPAP would help here? Because I do. She goes, yes, I've felt this way before. CPAP helped. I said, okay. Well, I put the CPAP on her, and about 5 minutes into the transport, she looked at me and said, it's a lot worse. It's a lot worse. And I said, okay. I listened to her lungs, and they went from mostly clear with a little bit of fluid to absolutely full of fluid. And what happened there is that she was having an issue with pulmonary hypertension. She was right there on the edge of ARDS, of that fluid going into her lungs very, very quickly and having that flash pulmonary edema. And by putting her on CPAP, which was the correct thing to do per protocol, per anything, you ask anybody. I talked to like 3 different cardiologists about it, and they all said, yes, that was correct. But I listened to podcasts on the entire way home, like stressing out because I felt like it was my fault. But no, it's just that pressure, that positive pressure pushed her over the edge and caused her lungs to fill up. She made a full recovery though. She ended up being okay. Um, let's see, PE. So that's pulmonary embolism. So we talked about embolisms. That is a blood clot that has formed somewhere in your body, most likely your lower limbs, your legs, your thighs, and has broken off and now has decided to go on a little adventure. And eventually it gets stuck. And a common place that these can get stuck is in the vasculature of your lungs. And so if one of the main arteries that feeds your lungs stops working, your muscle tissue can't work. Your alveoli can't exchange gas. Nothing is functioning properly, and you end up dying very quickly. There's also something called a saddle PE or a saddle pulmonary embolism, which is there's two like main branches of your veins right here that it'll just plop right there, and now the blood getting to your lungs from your heart to be oxygenated isn't getting to the capillaries. So you can breathe all you want, but that saddle PE, and it's called a saddle because it kind of straddles that bifurcation of the pulmonary artery. It it makes it to where it lowers the effectiveness, and it just builds and builds and builds and builds until you have a full occlusion, and those patients end up dying pretty quickly. The treatment for these kinds of PEs or pulmonary embolisms is to give them a lot of blood thinners, a lot of things that break up those clots, and just monitor, because you have to let that clot work itself out and filter itself out. All right, so I think I've covered pretty much everything I want to here. So let's see. We described the structures and the general functions of the respiratory system. We described the mechanisms that control breathing. We explained the process of gas exchange, and we talked about some common pathologies that affect the respiratory system. So some big overarching things to remember. I'm going to say this again. Trace that drop of blood through the heart. Trace that drop of blood through the entire heart. Get good at it, okay? Know which valves are which. That's an important part of that. Know the cardiac cycle, which is those atriums contracting, those ventricles contracting. Again, going back to the other day, you have four chambers of your heart, right? Your 2 atriums and your 2 ventricles, but it makes 4. Let's see. We talked about heart walls and all that. We talked a little bit about the electrical system of the heart, pulmonary edema and how it affects that gas exchange, because you cannot exchange gas in the alveoli if it is covered by fluid. Let's see. The main part, the difference between the upper airway and the lower airway. Think of that epiglottis as kind of that layer, that separation between your upper and lower airway. the different parts of the lower airway, the lobes of the lungs. Yeah, I think we covered it. Okay, guys, this was a lot. This was a lot, but it is a very important system, and I look forward to your questions tomorrow. Again, y'all, breathe. We're gonna get through this. You're all doing wonderfully. I am very, very proud of all of you, and I thank you for your time, your patience, and your effort. So email me if y'all need anything else at all. And yeah, if not, I will see y'all tomorrow.